Connaissance,
recherche,
science,
des sciences, mathématiques,
théorie,
physique,
philosophie,
conférences,
archéologie,
nature.
Two major explanations have been proposed, and we'll see them both into details now. The first explanation is based on the idea that we have preferences that vary over time. This is what we call time-linked inconsistency. The second explanation is based on the fact that we are probably mistaken if we think these actions have a major benefit. Yes, they do have a major benefit because we know that vaccination against certain diseases can prevent children from dying. But maybe, although these services or healthcare services have major benefits, the way these benefits are perceived is not equivalent to the importance of the benefit. So now the question is, how do we teach the benefits of a given behavior? So now let's come back to the first explanation, time-linked or time-related inconsistency. Let's take the example of vaccination, but we could say the same thing about mosquito nets. When you want to have your child vaccinated, you have to walk to the vaccination center, the child cries, and all this takes place today. But the benefit in the future, because in the future, the child is not going to develop measles. And so it's in the future and at a very unclear date. But today we know that based on the works of Ted O'Donoghue and Rabbit or even Leibson, we know, and that's true for us, but also true for people in Uganda or Daipur, that we think about the future in very different ways. For instance, we consider our decision in the present time based on our impulsions, whereas we look at the future on a more reasoned basis. So if you put people in a scanning machine or in an MRI machine, and you look at which part of their brain is shown when they reflect about benefits, cost-benefit arbitration in the present or in the future, you see that the areas in the brain which are turned on, even if you think about various issues like love and friendship, and you see that these parts are different whether you think about the present time or the future. So we have impulsions for today, and our impulsions tell us that costs we have to pay for today are high, and the benefit are not very high when you calculate them for the future, for instance. And you can make the calculation for all decisions you'll have to make in the future. Opening a savings account, for instance, it's going to cost you a lot of time today because you're very busy today, but in the future it's going to be easier because you'll have more free time. Vaccinating your child is going to be difficult now because you have lots of things to do, but you'll have plenty of time next month. Because when you think about next month, you compare the real cost of vaccination to the real benefits, which are very high. So when you think about making a decision in the future, you say, okay, yeah, it's obvious. I mean, the cost is very low, the benefit is very high, I will do it. But today the cost is very high because they're almost equal to the benefits, so it's not worth it. But when the future arrives, it becomes the present, and then again the costs seem very high. And this is why such a decision can be postponed till the kid is 2 years, he's not suffered measles, or he suffered measles, and it's already too late. And this could be a way to explain why people keep postponing vaccinating their children, whereas at the same time, when the child contracts measles, those parents who've not vaccinated their child will be willing to spend a lot of money to cure him then, because this is an immediate cost. If the child is not treated for measles, he's very sick today and could die tomorrow. So we see the contrast here, and parents are willing to pay huge amounts of money to treat their children. It's not because they don't love their children they don't vaccinate them, but this contrast helps explaining that the benefit of vaccination is always seen in the future, hence vaccination is postponed, whereas antibiotics have an immediate effect, so the cost is calculated in the now. So if a small benefit can be earned in the now, that can be enough to convince parents to do something, because you have a very small cost and a small benefit which balance out each other. So you can decide, yes, it's worth walking all the way to the medical center because I'm going to have a small benefit. In most developed countries, vaccination is compulsory, and you have specific delays. I mean, you have documents which are sent to you to tell you when you need to take your kid to get his shot. And you are sanctioned by the government if you do not have your children vaccinated. So we must vaccinate our children. There's obligation in developed countries, as we consider that in developed countries we have to make it an obligation. I wouldn't find it very shocking to say, well, let's give a small benefit to people in developing countries, because it would be very difficult to make it mandatory. But in a world where time-related inconsistencies are important, subsidies like lentils or constraints, like in our case where we have an obligation to provide vaccination, can be justified for two reasons, and not just one. The traditional reason, i.e., I'm vaccinating my child against measles, and that's going to give protection to the other children as well, because measles is a highly contagious disease. So there is a benefit not just to my child, but to the entire society. So you impose things to people, because that's what the principle for obligatory vaccination is based upon. Even if people see a very small benefit to vaccinating their children against measles, at a society level, it's very important we maintain this obligation to eradicate measles. And apart from this external principle, there is what I call the internalities, which describe the fact that these encouragements or obligations can help us adopt an optimal behavior for our own sake. Because if you ask someone, what are you going to do next month? He or she is going to answer, I'm going to have my child vaccinated. So a person who would take a decision in the now is always blurring the person, the logic, rational person who wishes his or her kid to be vaccinated in the future. So making it compulsory or offering an encouragement allows to bring together these two sides of our personalities. Yet, if time-related inconsistencies is the major problem, problem, then constraints or encouragements are means to help people, but not necessarily the only means. There are other means available. Richard Thaler and Gesserstein call it the nudging. That's, sort of pushing people in the right direction. And these are marketing techniques, which we all know very well, to encourage people make choices which they feel are appropriate. For instance, what's very popular at the moment is to offer options by defect. When you have to make a decision, for instance, the decision which is made for you, if you can't make a choice, would be the appropriate decision. But this does not apply to vaccination, but could apply to vaccination. For instance, we could decide that if you take your child to a vaccination center, he is going to get a vaccine shot unless you're opposed to that. That's the case for iodine-enriched salt, for instance. You have to go a long way if you want non-iodine-enriched salt today, because the decision has been made to provide you with a supplement of iodine. So that's one example of nudging. It's encouraging people in behaving in a certain way. And this is accepting constraints for oneself. One example, that of smoking, which is also important and interesting because cigarette is a genuine healthcare pandemic in developing countries. So cigarettes, tobacco, is a genuine example in which people aware of their time-linked inconsistencies would like to be forced to quit smoking and, for instance, to get cigarettes illegal in the coming months. So to achieve that, a microcredit bank has offered a certain number of smokers a contract which is called CARES, which is a contract that smokers would sign with themselves. It's a financial product which is not very attractive. You open a saving account with no interest. You make regular deposits on this account with a minimum of 50 pesos, which is a very small deposit. You make regular deposits. The bank would encourage people to make the equivalent sum of money as the money they would have spent on cigarettes. And 6 months later, at a random date, someone would come to your house and test you for the presence of nicotine in your system. And if you still smoke, your savings, you lose your saving. Okay, not very attractive as a financial product. Nobody would subscribe to this product if they didn't want to really quit smoking. And to check this, they made sure that non-smokers were not allowed to open the savings account. But for non-smokers, it's not bad because you have someone coming to collect your savings on a daily basis. But for smokers, that's probably not a very favorable product. So the program was assessed by two researchers, Dean Carlin and John Zinman, first to see which people would select this financial instrument. So the program was offered to 781 smokers, selected amongst 2,000 smokers. This is not the most popular financial instrument of the year, but 83 people, that's 11% of the people, accepted to subscribe to the program. 6 months later, they all underwent the control test. 11% of the people in the test group, so these 781 people, not just those who accepted to sign for the program, 11% had quit smoking and 8% in the control group. So the difference is 3 percentage points. In order to determine the impact of the program. I cannot compare the number of smokers who quit smoking amongst these 83 and compare that to the control group, because amongst these 83 people who accepted to follow the program, you have people who have a genuine desire to quit smoking, otherwise they would never have enrolled in the program. So in order to determine the impact of the program, we see that at 3 percentage points. But if we consider that this impact is due to all those who enrolled in the program, we would divide the 3 percentage points by the 11% of people who have enrolled in the program, and the effect of the program is, as shown by the equation, of 30%. So this program increased the success rate by 30%. So it's not, you don't have a large number of people enrolling with this program, but when they do, it is quite efficient. And you have a 30% increase in the number of people who quit smoking. So therefore, through this program, we have a proof that time-related inconsistencies do play a role, but we also have a proof that a certain number of people are aware of these issues, because 11% people have accepted to enroll with this financial program, which was not to their benefit, but because they really wanted to quit smoking and they realized that this was probably the best way to do it. Very similar, another similar program that you're probably familiar with is the Weight Watchers program, where you have the pressure of the group when you're ashamed in front of your group if you don't succeed losing weight. So people do suffer from these problems of time-related inconsistencies, but they're not naive. They're very much aware of that. And next week we'll see that there are other areas in which people suffer these problems of inconsistencies, but knowing that, being aware of that, they take measures to fight against this. Yet if people are aware of these inconsistencies, then they should be capable of organizing. They should stop postponing vaccination, because they know that despite they consider the cost is very high today and not very high tomorrow, they should be able to realize that the situation is going to be yet again the same tomorrow. So somebody aware of these inconsistencies would probably decide, okay, I'm still doing it today, and would actually do it today, in the now. So that proves that this explanation of time-related inconsistencies is meaningful. It cannot explain it cannot be the explanation of all the problems. So there is another explanation, which is that of how benefits are perceived, and more specifically, the low demand and sensitivity to the cost of preventative health care. The low demand and high sensitivity to cost probably derive from the fact that we tend to underestimate the benefits of preventative medicine and overestimate the benefits of curative medicine. So why would it be the case? Well, it's very difficult to be informed about your health status, especially for curative care. Most diseases just disappear by themselves. You have a flu, you stay in bed for a few days, and you no longer have a flu. And as the disease goes away by itself, any treatment seems sufficient. You go and see a doctor wearing his white coat and gives you a shot of antibiotic, you feel better, and you'll come back and see him if you don't feel well on another week. And if you go and see the young nurse in the healthcare centre, and she says, well, you have a flu, take an aspirin, go to bed and you'll be better, you'll be angry, because they will not have done anything for you. So you won't make a link between the absence of action and your healing, because she's done nothing. But you will make a connection between your getting better and the antibiotics given to you by the private doctor. So there is a big demand for drugs, even in or medicine, even in cases where you get no prescription, because it's impossible for each person to understand all the biology, to understand everything that's going on. A private doctor, not regulated, and once again, who is not a trained doctor, they have an interest in giving you what you want to get instead of what you need, because that's a means for him to maximize his income. Now, for preventative healthcare, they prevent the disease from occurring. So you can't observe any disease, and there is no direct link established between the vaccine and the fact that you're not sick. And then, as you've been vaccinated, then other children around you get less sick, and this makes it even more difficult to assess. So it's important to inform people, and we need an effort from public authorities to emphasize the role of preventative medicine. So let's talk about preventative medicine with 3 conclusions on which I'll focus more into details in the next quarter of an hour. The first conclusion is that well-targeted information is useful, but just saying things in general is not useful. You don't want to provide too generic information to people. You want well-targeted information. Second conclusion, education is part of public health policies. Last week we said that public health was part of the education policy. Well, that's another way of seeing the problem. And then learning is possible through action, through your own experience and through the example given by the others.
Right, so for the first point then, I'd like to talk about the preventative care with regard to AIDS, and in particular that with regard to young people. Now, the preventative care for with regard to AIDS, young people are considered as a window for opportunity, because young people don't yet have AIDS, and their sexual behaviour and such has not yet been written in stone, if you like, so they're more flexible. And a number of countries have managed to stem the spread of AIDS, in Uganda, for example, by focusing particularly on young people in schools. So it's interesting to look at the Kenyan government's response. For its part, it's also implemented school education instruction with regard to AIDS. Now, in a number of countries, preventative care education in schools gives rise to a certain amount of consensus. Now, in Kenya, this also involves church, etc. But this all built on a message which is very popular in East Africa, and it's called ABCD. We're talking about Tanzania, Uganda, etc. ABCD stands for abstain, be faithful, use a condom, or you die. So obviously this is in rank order. So in schools, focus is made upon abstinence in primary schools and right the way through to second year. And if abstinence is not possible, well, then remain faithful to your partner. And if that's not possible, well, then use a condom. So the rhetoric of public health in Kenya, at least, is one which focuses on circumventing the risk. Because only 100%, I mean, obviously 100% effective would be to be abstinent. But in any public health issue, particularly with regard to risk prevention, there's a choice to be made at the outset. Either you focus on totally circumventing the risk, or drawing down the risk. Now, total avoidance of risk, in other words, if you persuade teenagers and kids that it's best to be abstinent, well, then by doing so, if they sign up to that, well, they'll be out of any danger. Now, risk prevention is to involve changing behavior. So it might not be 100% effective, but it might be more straightforward for people to sign up to. So we can imagine then that we can have a total prevention on one hand, as opposed to drawing down risk. And then ABCD message, of course, is one that's built entirely upon circumventing the risk, avoiding the risks in the first place. So we've worked in conjunction with the Kenyan government and in conjunction also with a Kenyan NGO and a Kenyan doctor in order to appraise what we're dealing with regard to risk reduction strategy, mainstream strategy, and another strategy involving avoiding risks as a whole. So ABCD program, education against AIDS, this is rolled out in schools, but in principle at least, teachers don't teach it very well because they haven't received any upstream training and they don't feel very comfortable with the topic. And so without any previous instruction, teachers aren't really effective in imparting this program, so it's not effective. So the government has a teacher training cell, which is quite sluggish, but actually tries to go from one school to another to provide everybody training. So this is unfolding as we speak, but it'll take a number of years. So this program, this training, if you like, is incremental. It's focused on one region, say, working in conjunction with NGO and government, to make sure that this progress is done in a randomized fashion in order to be able to compare results where teachers have received training and compare those results with other schools where teachers haven't been trained. So we chose 370 schools where the program has been rolled out over a number of years, and 183 schools in addition to that. So the trainers were from the government. Now, in 35 of these schools, ICS, the NGO in question, had organized, in conjunction with Pascaline Dula, who was part of the research team, organized a program which was focused upon risk reduction, drawing down risk, to draw a contrast with total avoidance of the risk. And this program was dubbed Sugar Daddy. Now, I think this speaks for itself, really, Sugar Daddy, it speaks for itself, the name. But a number of teenagers in Kenya, and this is true for East Africa as a whole, a lot of teenagers have sexual relationships with sugar daddies, older partners, and they're transactional in nature. They're not prostitution, but I don't know. Maybe there might be exchange of gift, maybe a dress given to the woman. So intergenerational sexual relationships, therefore, is one of the major factor for spreading AIDS, because men are often HIV positive, and obviously they contaminate their partner. So the rate of contamination of girls between 15 and 19 years of age is 5 times higher than boys in the same age bracket. And this is also true, the ratio with regard to men. So this intergenerational issue is a significant one when we think about AIDS, the spread of AIDS. And this latter would be drawn down significantly if this was knocked on the head. But young girls, we saw that in initial investigation, girls are not aware of the difference between contamination rates between teenagers and older people. They think that older men are dangerous because, these are perilous. A young chap you meet in a disco, for example, and some other people are considered not perilous because some men, they feel that they are very faithful to their partners, so they would offer no risk for them. And obviously, there's a high level of risk for falling pregnant for these women. So what the NGO did was very straightforward. They ran a program which lasted, 30 minutes, 45 minutes, which involved showing a video, UNICEF video, on sugar daddies. A small story where a young girl manages to escape from her sugar daddy, etc. And then also they show statistics of contamination among younger people, young women and older men and older women. And the older women's incidence of contaminations is similar to young girls' incidence of contamination. So here are the two programs: total eradication, total avoidance of risk versus reduction of risk, and that's the sugar daddy program. So what are the findings? Well, brief parenthesis. How can you gauge the results of a program of this type? Well, what's generally done, because these kids, okay, even if they've got risk behavior, they show risk behavior, the contamination rate of AIDS will be very low. Thank goodness for that. So how can we gauge the effectiveness of the program? Well, what's generally done is you ask questions to the kids at the end of the program on their knowledge, gauge their knowledge, and look at their behavior. Now, the problem of only using a questionnaire to gauge behavior is that, well, young people could have learned that, well, it's better to say, I use condoms, even though, and they have no sexual relationships, of course, and it's better for them to say that rather than, even if it's not true. So you need a yardstick which is objective to gauge risky sexual behavior or sexual behavior per se. Now, there's one modus operandi that can be done to know whether young girls are pregnant. If you take one generation, well, you'll see the findings in a second. There's lots of young girls fall pregnant between 14, in the age bracket 14 to 17, and it's the same behavior here that makes the girls pregnant and contract AIDS. For example, obviously through non-protected sex, and obviously when you use condoms and when you have less sexual relationships, then the incidence of contracting AIDS is less, obviously. And so obviously, the reduction of the prevalence of AIDS is desirable, obviously. So with regard to teacher training under the aegis of the program ABCD, what happened there? Well, trained teachers, thank goodness for that, had more discussions in their classrooms about AIDS. However, the training had little impact on knowledge, little impact on reported behavior, and no incidence whatsoever on pregnancies in the 2 or 3 years following the classroom raising awareness. So 14% of girls who were involved in the first survey at 50 and the age 15, they had 14% had a kid in the following 3 years. And there's no change whatsoever there, 14.4 and 14.3%. And after 5 years, it moves up to 30%. No change there whatsoever. So the program had no incidence. So it's not a program that has any success whatsoever. Now, there are very little programs that have involved pregnancies, but other programs have looked at reported behavior, and all appraisals, all evaluations that we did in Mexico, that we did in Tanzania or in other areas of the world, all the evaluations that have been done by different teams as well are based on similar collection of data, looking at risk avoidance, etc., have similar results. And Michael Kramer and Mr. Miguel, for example, wanted to look at trying to avoid contracting parasites and wear shoes to avoid bilharzia parasites entering your feet. Obviously, it was important to impart information about them wearing shoes, the importance of wearing shoes, and not necessarily wading into rivers to fish. Now, what about the findings for the sugar daddy program? Well, this gave rise to a reported drop in sexual activity and, well, a slight increase as well of instance of relationships with younger sexual partners, but by using condoms this time. And the results, the findings, well, this is the reported results. I mean, who knows what happens in reality, but I mean, this looks as though it's worked very well, because after a year, these are the results after a year, you can see that there's a strong drop in the number of pregnancies, 5.4 to 3.7, which is very significant in terms of ratios, and even more significant drop with regard to pregnancy rates with older partners. And this is what's sought to mitigate. So 2.4% to 0.79. So this is a 64% drop in terms of ratio, in terms of pregnancy incidence. So you can see the contrast. Between everybody's dangerous, just stay home, locked in your own home, which isn't very good for teenagers, is it? By way of a message, and then another message: be careful of sugar daddies. Their contamination rate is higher. This obviously has will expose you to a huge amount of risk, and we can see the figures there on the previous board. So that's the overriding message. What about the specific message, that good takeaways for people? Now, education is a public health policy. To be at school, for example, learn to read, etc. This shows that public health and education go hand in hand. Still, with the same sample group of schools, they were very useful for work conducted on AIDS prevention. ICS, with financing, managed to, in conjunction with Partnership for Child Development, a British NGO, they were able to distribute uniforms to the same schools. Now, dropping out of school for girls went from 18 to 12% dropping out of school. So it went from 18 to 12% 3 years down the road. And for pregnancy, these are the findings, the previous findings, remember. So 14.3% after 3 years, and dropped down to 10.6%, 30.2% 3 years down the road. And then with the uniformed statistics are in green, so drew down from 30% to 30.2% to 26.1%. So here you can see that pregnancy is obviously less. So education, therefore, is in and of itself a public health tool. And the reason why is that a young girl in Kenya, if she doesn't go to school, then she doesn't enjoy any status. She's in her family, she has to help with household tasks. But young girls prefer to marry, go out of the family home in order to have social status, and then they're a lot more likely, therefore, to have a child at a younger age. The third point that I wish to talk to you about, and this is training through example, training through action and by example. Now, over and beyond the role of information, customary habits can play a role. In other words, just getting used to adopting a certain type of behavior, that can prompt you to continue with that particular type of behavior. Because, by force of habit, you continue in the same vein. Or because you're actually learning the benefits of changing your behavior. And you understand those benefits. So, to see whether that was actually the case, Pascaline Dupas did an interesting experiment with mosquito nets in Kenya. Not the same one as you saw before. This is an experiment, basically, which doesn't use health centres and pregnant women, but simply distributes vouchers for drawing down the cost of mosquito nets. So again, these are mosquito repellent impregnated mosquito nets to protect against malaria. So the real price is, $5 for these mosquito nets, these specially treated mosquito nets. And Pascaline Dupas chose 644 households and handed out vouchers to draw down the cost of the mosquito net between $0 and $3.8. Everybody got on board with this, obviously received a voucher, but the value of the voucher changed from one household to another. So, okay, now you'll see that people are more likely to buy a mosquito I mean, they're more likely to take the mosquito net if it's free rather than if they had to pay, even though they're paying less than if they were to pay for a mosquito net without the voucher. So 98% right down to 11%. And, even at a low price, 98% down to 59%. When you go from $0 to $1. The second thing, this is a question which is worth taking into consideration. Do they use their mosquito nets once they've got it, whether they paid for it or they haven't? This might be interesting because a mosquito net is a mosquito net at the end of the day, isn't it? Whether you've paid for it or not. So it may not seem to be a genuine question, but it is actually a genuine question bearing upon public health. And this gives rise to heated discussion because from a mainstream point of view, you would say, well, look, if you've got a mosquito net, well, you're going to use it unless you don't have room to deploy it, whatever. So the price of purchase of a mosquito net shouldn't really not stop you putting up your net. Well, then there are two approaches. Social marketing says, okay, we need to subsidize mosquito nets, so we should be selling them at $3 rather than $5 and not just handing them out for two reasons. The first is that by giving them for free, it means that people don't need to collect them necessarily, and they might not even use them at the end of the day. And the second reason, the simple fact that you're paying for a good means that that good is more precious to you. If it's free, you might think, well, it's not worth it, I don't know. I mean, if people are giving it for free anyway, it means that it's probably worthless anyway. So the fact that you've paid something makes the good that you've bought useful. But this proves that this is not the case. The figures here show that this is not the case. And this experiment was conducted in different variety of backdrops. So the argument doesn't hold water. So it would lead us more to say that you need to give out the mosquito nets, quite simply, because there's more people that take those mosquito nets, but the more there is a mosquito net, more the prevalence of mosquito nets in a region, the more mosquitoes die because they're dying of hunger, and so they leave the region. So it's more important that the penetration rate, the effective penetration rate or coverage rate of mosquitoes is high, and it's better to give them free rather than subsidize them. And this means, obviously people then need, once they've got these mosquito nets, they need to be able to use them properly. And then you could say, and some people have said this, well, if you start handing out mosquito nets, people are going to get used to the fact that you just hand them out free, and they'll never want to buy the mosquito nets.
That's a possibility, but we could argue also that once they have the net, they will use it, and having used it, they will realize what the benefits are, and at the end of the day, when you'll start selling the mosquito net for 100 shillings, you'll have a larger number of people who will accept to take it and buy it. So, a few months later, after we visited these people and offered mosquito nets at different prices, so our researcher went back in the field with the NGO called Together Against Mosquito, and they offered all families a mosquito net for 100 shillings. That's a highly subsidized price, but they had to pay for something. So what we wanted to see was how people would react. Would they accept to pay because they were very happy with the benefits, or would they expect to get it for free? So you see here that when the net costs 100 shilling, it's their second mosquito net. But the buying rate in CC treatment is for free, and control is when they have to pay. So when the mosquito net has been for free at the beginning, you have twice as many people who would buy it afterwards because they've seen the benefit of it. And for these households. Yes, fine, but for those to whom you tried to sell your mosquito nets, they will wait and get it for free. And in that case, they will use them less. But against this effect, there is another effect. The more friends you have using a mosquito net, the better you can see the impact of using a mosquito net and the benefit of that. So the question is, if you have a large number of people using a mosquito net, will it have an impact on your purchasing behavior, even if you have to pay for your mosquito net? So that's the result. The share of households who bought the mosquito net for the second time, 50% on average amongst what that was in the control group, with 33 received it for free. But if all received it free, then people would use more mosquito nets and would buy more mosquito nets on a second occasion. So you're more prompted to buy mosquito nets if you have a large number of neighbors using mosquito nets. Now, in conclusion to everything we said today, I'd like to talk about the consequences of everything we said in terms of economic policies. The first consequence, the first impact, is that in the field of healthcare, market policies don't necessarily lead to a situation in which preventative medicine is offered or asked for. So when you talk about the privatization of medical system in India, because very often people would say, all we need to do is privatize the health sector. But we see that in a country where preventative medicine is very much needed, this is not possible. Another point is that there are policies which are very popular in the US, which aim at creating markets where there is no market and have people buy for mosquito nets at a high enough price for mosquito nets to be profitable. But this is an illusion because these people have no expectations. So the need to be introduced, and politicians need to accept to lose money on these initiatives because that's for public good. And we cannot rely on local authorities to impose preventative medicine to be offered. Then another conclusion is that the quality of care depends on underlying demand, because if there is demand for curative medicine but absence of preventative medicine demand, in such a context like in India, where you have a dangerous private sector, the local authority has to emerge and offer or regulate public health healthcare offering. If this is not done, it's going to lead to a very dangerous situation because healthcare will be provided by dangerous professionals. And it's very difficult, as we saw through the Indian example, it's very difficult to maintain a system with a top-bottom approach. So the good quality of healthcare needs to become a political claim. A last conclusion is that an effort supported or regulated by public services should be very helpful to encourage the development of preventative medicine. Second conclusion, or second large conclusion, how can we encourage a change in behavior? Well, we've said that on the short term, price and costs are important, so we need to establish prices in a way that makes it possible for us to do as much as possible. And subsidies for the total payment of preventative medicine can be very helpful, like paying for condoms or mosquito nets, etc., etc. Encouragements Very often we talk about sustainability at the moment, in terms of financial sustainability. The idea being that people should pay not just for the reason I explained, but also because it's important that the money generated by people themselves allow the project to be sustainable. But ensuring the sustainability of a project is something that we talk a lot about. But we need and look at this in a very detached manner and see whether having people pay for a service is really profitable. But in some areas, having people pay for a service would be less profitable in terms of benefit than not having them pay at all. Here for bed nets, for instance, the cost per life saved, $284 when bed nets are given for free, but when they're subsidized at 90%, which is usually the average level of subsidy. So how come it's more profitable to give the nets for free than to have people pay for 10% of their actual value? Well, because you never get all the money you ask to people. And the second important thing is all the externalities I told you about. Having a bed net, with a bed net you also have threshold, and you need to have as large a coverage as possible. If you just have a few bed nets, the mosquitoes would just fly and bite somebody in the house next door, and the effect is not at its full potential. So it's better to give out a large number of mosquito nets for free and benefit from this threshold effect or coverage effect. Second example, that of vaccination. There is a fixed cost when you send a doctor to vaccinate the children. So the more children you vaccine, the better. If you realize that you have more children if you also give a kilo of lentils, and you look at the cost of vaccinating children with or without lentils, you realize that it's more expensive to offer vaccination without offering the parents some lentils. Third example, which is for the intestinal deworming, and that's the same system. There is a fixed cost for nurses to come to school, so the larger the number of children being dewormed in one operation, the better. So we need to use prices and not be afraid of free service, even if we have this idea, okay, we need this action to be sustainable, we need beneficiaries to pay for a certain amount. It's not necessarily profitable if you look at profitability with regards to benefit. Second, encouragements or constraints can also be efficient to encourage us having a preventative behavior. So we could use cross subsidies to encourage certain behaviors. For instance, the WHO and the UNICEF distribute mosquito nets when they organize vaccination campaigns against measles. And finally, and this will be my last word, on the short term we need to use prices, but on the long term we need to better understand how we can inform people better about preventative medicine. We need and find efficient ways to communicate information. And credibility is key, but very often this credibility is wasted by states who try and use that credibility to do something different. For instance, persuading people to get sterilized. Second point, it's important to focus on an information on which you have levers, like the Sugar Daddy program being more efficient than the ABCD program. And third, this is something we didn't touch upon, but there are many data available coming from non-experimental research program, but it's useful to use mass media like TV, especially in developed countries. In Brazil and India, we've shown that with the progression of cable TV, we've shown that TV and TV programs and series are linked to a reduction in fertility, because the heroes in these series have fewer children, and girls therefore tend to have less children by imitation. That's all for tonight. Thank you for your attention.